Welcome viewers, today we are going to discuss the pharmacology of the ACE inhibitors. ACE are the angiotensin converting enzymes inhibitors. Very briefly, angiotensin converting enzyme inhibitors basically relax the blood vessels or dilate the blood vessels. ACE inhibitors available in the market are the captopril, enalapril, lisinopril, ramipril, and others. ACE inhibitors were the fourth most prescribed drug in the congestive heart failure in the world. And among the ACE inhibitors, lisinopril was the second most prescribed drug in the congestive heart failure. Before going to discuss the pharmacology of the angiotensin converting enzyme inhibitors, let's have a look of the renin, angiotensin and the kinin system. Angiotensinogen is released by the liver and it will be converted to the angiotensin 1 by the enzyme renin. Angiotensin 1 is then converted to angiotensin 2, that is the most potent vasoconstrictor. Moreover, angiotensin 1 is also converted into angiotensin 1 to 7, which we will discuss later on. Angiotensin 2 is angiotensin 1 to angiotensin 2 is converted by the enzyme that is called ACE, that is the angiotensin converting enzyme. Angiotensin 2 has so many functions. Main function is that it will act on the zona glomerulosa and secrete the aldosterone. This aldosterone release will act on the principal cell of the collecting tubule of the nephron and results in the sodium retention, which will increase the blood pressure ultimately. Kininogen is another protein which is also released by the liver and it is converted to the bradykinin by the enzyme kallikrein. Bradykinin is the most potent vasodilator. Basically, this bradykinin is the negative feedback mechanism of this angiotensin 2 or angiotensin 1. Basically, bradykinin is then converted to the nitric oxide and the prostaglandin, and they will cause the vasodilation and the sodium excretion. If the vessels become dilated and the sodium is excreted from the body, obviously the blood pressure will go down. But here in the nature, bradykinin is converted by the angiotensin converting enzyme into the inactive form, that is bradykinin 1 to 7. So if the bradykinin bradykinin will not be able to dilate the vessels, is not been able to excrete the sodium, obviously they will constrict the vessels and favor in the angiotensin 2 and will definitely increase the blood pressure. Let's have a look on the ACE distribution. ACE are widely spread on the concentrated on the endothelial surface of the vasculatures, epithelial brush borders, renal proximal tubules, small intestine, placenta, choroid plexus. These are the lungs. If we have the cross section of this area and magnify this cross section, we have the bronchioles over here and the alveoli and veins, arteries and the capillaries. If we magnify this capillary area, these are the vascular area. These are the vascular tissues. It's a cross section of the vascular tissue. If you have a close look of this, we saw that it's a luminal wall of this vessel lumen. There are endothelial cells On these endothelial cells, these pin-like structures are present. The head of the pin are the ACE, angiotensin converting enzyme. If we have a close look or magnify this particular area of the head of this pin, which is the angiotensin converting enzyme located over here, then you can see that the N domain and the C domain, between these N domain and the C domain, both of these are these head of these pins. Between these two domains, between these two heads, the ACE are present on the vasculature tissues of the endothelial cells. This is basically the presence of the distribution of the angiotensin converting enzymes. Now have a close look to the renin angiotensin aldosterone system. What happened? Let's start from here. Suppose the patient is bleeding, his blood pressure is going down. Obviously the message will go to the from the afferent arterioles to the juxtaglomerular apparatus, particularly in the juxtaglomerular apparatus at the baroreceptors and the chemoreceptors, that the blood pressure is going down, GFR is going down. What will be happen? They will honor this message that blood pressure is going down, please release the renin. So these baroreceptors, these specialized cells, these are called the juxtaglomerular apparatus, will release the renin from these baroreceptors or the pocasins. These baroreceptors release the renin. This renin is an enzyme. It needs definitely, it will goes to the circulation. It will need definitely some substrate to act on, to act. Liver secretes so many, in the liver, hepatocytes secrete so many proteins, one alpha globulins, beta globulins, but not the gamma globulins. There are some specialized proteins also released by this liver. These are called the angiotensinogen. This angiotensinogen is then converted, when comes into the circulation, then it will converted into angiotensin 1 by the enzyme that is called renin. This angiotensin 1 is an inactive form. It will definitely want to go into the active form, that is the angiotensin 2, but this will be only happen when the angiotensin converting enzyme will act on this angiotensin 1. This angiotensin converting enzyme will release from the surface of the pulmonary and the renal endothelial tissues, which we already discussed in the previous slides, that are present in the lungs. These angiotensin converting enzymes will convert the angiotensin 1 into angiotensin 2. Angiotensin 2, which I already discussed, that the angiotensin 2 is a potent vasoconstrictor, and how there are so many functions of the angiotensin 2. Let's discuss one by one. One of the function of the angiotensin 2 is that it will send the stimulatory signal to the sympathetic activity, to the sympathetic pathway. In this sympathetic pathway, this will send angiotensin 2 will send the signal to the hypothalamus of the posterior pituitary, and it will release the ADH, and obviously the blood pressure will increase. Another system of angiotensin 2 is that it will send the stimulatory signal to the tubular sodium reabsorption and excretion and the water retention. It will tubular secretions, that the sodium will reabsorb, potassium will come into the lumen, and calcium will obviously passive transport, chloride is passive with the passive transport will come back from the lumen into the interstitium, and the water will also with the passive transport come back from the lumen into the interstitium and the systemic circulation. If this will happen, sodium and water will come in the systemic circulation. The water and salt retain in the body. So effective circulating volume increase, blood volume increase, cardiac output increase, perfusion of the juxtaglomerular apparatus increases, and obviously blood pressure increases. Another function of this angiotensin 2 is that it will act on the adrenal cortex. It will act on the adrenal cortex and send the stimulatory signal to the adrenal cortex, which will secrete the aldosterone secretion. These aldosterone secretion will definitely act in such a way that they will retain the sodium into the body and retain the water into the body and retain the chloride into the body and excrete the potassium back into the lumen for the excretion. As the sodium and water will retain in the body, so again the water and salt retention happened, effective circulation volume or the blood volume increases and the perfusion of the juxtaglomerular apparatus increases and the blood pressure increases. Another function of the angiotensin 2 is that it will act, as we said, that these are the potent vasoconstrictor. It will act not only on the venular side but also on the arterial side also. Arteriolar vasoconstriction increase the blood pressure. Arterial vasoconstriction increase the blood pressure, and so that we can say that it will also angiotensin 2 will constrict the blood vessels, and reason is results in the increase in the blood pressure. Another function of angiotensin 2 is that it would send the stimulatory signal to the pituitary glands or the posterior lobe. These posterior pituitary gland release the ADH secretions, antidiuretic hormone secretions. These antidiuretic hormone secretion will send the stimulatory signal to the collecting duct, and the water will reabsorb through the passive transport. If the water is reabsorbed, obviously blood volume is increased, so water is retained and so the blood pressure is increased. As the blood pressure is increased by this angiotensin 2 functions, water and salt retention increases, effective circulation volume increases, perfusion of the juxtaglomerular apparatus increases. What will be happen? Blood pressure is increases. What will be happen? An inhibitory signal will send from here. The inhibitory signal sent from here to the juxtaglomerular apparatus. Please, the blood pressure is going high. Please don't release the renin. They will definitely on the basis of this inhibitory signal. As the blood pressure is going, this compensatory mechanism will be active and will send the signal to the juxtaglomerular apparatus. Please don't release the renin. If we talk about the juxtaglomerular apparatus, let's start from here. These are the afferent arterioles. These are the efferent arterioles. It is the glomerulus apparatus. The afferent arterioles. At the afferent arterioles, there are the juxtaglomerular cells. These are the juxtaglomerular cells. Basically, juxtaglomerular cells are the collective structure of this collective structure of the some specialized cells of efferent arterioles and the uh, end portion of the distal convoluted tubule and start portion of the collecting tubule. The efferent arterioles has some specialized cells which are the basically called the baroreceptors, which will sense the pressure. Which you can say these are the pressure sensors. These smooth muscle cells are become specialized in of these efferent arterioles, and they are called the baroreceptors. They will sense the pressure of the blood. If the blood pressure is going down, they will sense that the pressure is going down, so we have to release the renin. There are two functions of these. One, the function of these specialized cells is that there are the pressure sensors, and other is that they are the they also release the renin. Their function is to release the renin. These are the macula densa. These macula densa basically are present. These cells are present on the start portion of the distal convoluted tubule and the end portion of the distal convoluted tubule and start portion of the collecting tubule. End portion of the distal convoluted tubule and start portion of the collecting tubules. These dark cells, these longitudinal cells are called the macula densa. Basically, these macula densa are the sodium sensors. These are the chemical sensors. So we can say that these are the chemoreceptors. They love to taste the sodium. If the sodium is level in this area is very low, they will send message to these Pocassin cells. These are the baroreceptors. Through these connective tissues, through the connective cells, please do something. The pressure of the sodium is very low. Please do something, and please secrete the renin. So these juxtaglomerular apparatus, from these juxtaglomerular apparatus, the baroreceptors, the Pocassin cells will release the renin. These are the sympathetic fibers which will send the message. These send the message to the carotid sinus and send as the blood pressure is going down. This message will goes to the carotid sinus and send these from there. The carotid sinus will send the message to the brain through the glossopharyngeal nerve, that is the ninth cranial nerve, and it will from there the sympathetic activity will increase, and it will also send the message to this baroreceptor also from that portion by secreting the norepinephrine, and this norepinephrine will act on these send message by secreting norepinephrine from the post synaptic neuron and send the message to the baroreceptors. Please send these extraglomerular apparatus baroreceptors, please secrete the renin. It's all about the story of this juxtaglomerular apparatus. These are some informations which we can. Now, mechanism of actions of the ACE inhibitors. As we discussed later, the angiotensinogen is secreted by the liver, and angiotensinogen is converted to the angiotensin 1 by the enzyme renin, and angiotensin 1 is then converted to angiotensin 2 by the enzyme ACE, and this angiotensin 2 receptor act on the angiotensin 2 type 1 receptors, and these angiotensin 2 type 1 receptors will definitely on acting the angiotensin 2 on this type 1 receptors, following functions happened: vasoconstriction, aldosterone release, sodium retention, pro-inflammatory oxidative stress, proliferation of the myocytes. And if the vasoconstriction, aldosterone and the aldosterone release, sodium is retained in the body, the blood pressure will definitely increased. What will happen next? Another system that we already discussed, the parallel system, which is maintaining the increase in this blood pressure, is the kininogen. The kininogen is another protein which is released by the liver, which is converted to bradykinin by the kallikrein enzyme. This bradykinin is then converted to the kinin B2, is act on the kinin B2 receptors and cause the vasodilation. As we discussed later, the bradykinin is the potent vasodilator. As previously we said, these are the angiotensin 2 are the potent vasoconstrictors and the bradykinin are the potent vasodilators. So as they are the potent vasodilator, they will inhibit the blood pressure increase and the blood pressure will be going down. But meanwhile, as the normal system is going on, if the blood pressure is going high, if the blood pressure is going down, what will be happen? This bradykinin will be converted into the bradykinin 1 to 7. It is the inactive form. In other words, we can say that the ACE is inactivate the bradykinin. So if the ACE is inactivating the bradykinin, so this vasodilation activity will be finished, will be inactivated, and it will follow this vasoconstrictor activity and the blood pressure is going high. Now apply the ACE inhibitors. Suppose the blood pressure is high, then again suppose the blood pressure is high, what will be happen? What should we do? We should do that we must not constrict the vessels. We must not constrict the vessels. We must not release the aldosterone. We must not retain the water in the body, sodium in the body and water in the body. We must not release the water in the body, and moreover retain the water in the body. And what should we do? Another way round, if the blood pressure is going high, we must not need the bradykinin will be inactivated. It must be work like this. It will vasodilate, so the blood pressure is going down. If the blood pressure is going high, then we apply this ACE inhibitor. We inhibit the angiotensin converting enzyme. What will be happen here at the agiotensinogen cycle? What will be happen? The angiotensin 2 will be inhibited. It will not act on the angiotensin type 2 receptors. There will not be vasoconstriction. There will not be aldosterone release. There will not be sodium retention, and the blood pressure will fall down. Here, if we check the if the ACE inhibitors are also not inactivating the bradykinin, what will be happen? These bradykinin will definitely cause the vasodilation and excrete the sodium from the body, and blood pressure will gone down. Next, another cycle is also, which I'll not discuss over here. And anyhow, okay, let's have a look of another cycle, that is of angiotensin converting enzyme inhibitor 2. It is a normal, which we discuss later on. The vasoconstriction, the normal one, and if another thing, angiotensin 1 is also converting to angiotensin 1/7, as we discussed previously. Angiotensin 1/7. This angiotensin 1/7 is a vasodilator. Is a vasodilator, as that of the bradykinin. What does the angiotensin converting enzyme do? Angiotensin converting enzyme will convert this angiotensin 1/7 to inactive angiotensin 1/5. Angiotensin 1 to as that of the bradykinin. The bradykinin will converting into the inactive bradykinin. So the same function of this of bradykinin will be happened with this angiotensin 1 to angiotensin 1/7. So it is another. If the blood pressure is going high, what will be happened? We will apply the ACE inhibitors. What they will done? ACE inhibitors will inhibit the angiotensin conversion of angiotensin 1 to angiotensin 2, and at the same time, same way, angiotensin 1/7 to angiotensin 1/5, and obviously it will decrease the blood pressure. This will also decrease the blood pressure. Okay. Let's have a look to the clinical use of the ACE inhibitors. Clinical use of the ACE inhibitors. Let's have a look to the clinical use of the ACE inhibitors. These are used as an antihypertensive. About 50% response, 90% with the diuretic. Decrease the systemic vascular resistance, decrease the stresses or reflex-induced sympathetic stimulation, and there is no effect on the heart rate. Increase the sodium excretion. As the sodium is excreted from the body, you know well, the blood volume is decreased and the blood pressure is decreased. Another one, that is a congestive heart failure. It is used in the congestive heart failure. Decrease the vascular resistance, blood volume and heart rate also, and increase the cardiac output. No change in the myocardial oxygen consumption. It is also used in the diabetic nephropathy. Dilates the afferent and the efferent renal arterioles, decrease the glomerular capillary pressure. Side effect of and the contraindications. There are some common side effects of the angiotensin converting enzyme, and there are some rare side effects. First of all, discuss the common side effects. They are the dry cough and the photopathic potentials, that is also called the teratogenicity. 5 to 20% of the patient not suffer from this diabetic 5 to 10% of the patient suffer from the dry cough. Not dose related, occur within 1 week to 6 months. Women are more suffer with the dry cough as compared to men. May require cessation of the therapy. Fetal potentials, not teratogenic in the first trimester. Development defects in the second and the third trimester could be happened. The rare adverse effects are the angioedema. 0.1 to 5% of the patient is suffering from this angioedema, not dose related, occur within first week of the treatment of the therapy. Severe swelling of the mouth. What is the angioedema? Basically, it is the severe swelling of the mouth, tongue, lips, airways, may be life-threatening. Maybe, but I will say definitely life-threatening. Some other side effects are the rare side effects and some extremely rare side effects that may be the reversible. First of all, discuss the rare side effects. Other rare side effects are the hypotension, hyperkalemia, acute renal failure, and skin rashes. First of all, hypotension. First dose effect in the patient with the elevated plasma renal activity, salt depletion, congestive heart failure. It is the rare side effect of the when the patient is have the gone into the hypotension. Hyperkalemia, as you know well, it is the potassium retaining drug also in the patient with the renal insufficiency, particularly in the diabetic nephropathy, they will cause the hyperkalemia. Acute renal failure, patient with the renal stenosis, both arteries of the kidneys become narrow. Narrow stenosis become narrow, heart failure, volume depleted, and the skin rashes. Extremely rare, loss of taste, neutropenia, glycosuria, and the hepatotoxicity. These are reversible. If we withdraw the ACE inhibitors, we can avoid such kind of side effects. And the contraindication is that this must not be given in the acute renal failure patients, must not in the patient with the renal stenosis, heart failure. These are the must not be given in that patient. Hyperkalemia, patient suffering from the hyperkalemia already. Hypertensive patients must not be given in the hypertensive patients. These are the contraindicated in such patients. And moreover, the patient of the hepatic failure patients must not be given be treated with the ACE inhibitors. Mainly side effects, as we discussed later on: dry cough, hyperkalemia. What happened in the hyperkalemia? Muscle cramps and the urine abnormalities, respiratory distress, decreased cardiac contractility, electrocardiogram changes, and the reflexes. Its mnemonics is murder, M-U-R-D-E-R. M for muscle cramps, U for urine abnormality, R for respiratory distress, D for decreased cardiac contraction or contractility, E for electrocardiogram changes, and R for reflexes. Murder. Next adverse effect, as we discussed later, it is a teratogenicity in the second and third trimester of the pregnancy, and last one is the hypotension. Angioedema, this is the cases of the angioedema. This I already said these book said these may be life-threatening, but I said it definitely the life-threatening situation. Moreover, drug interactions. There are some drug interaction with the antacids, with the capsaicin, NSAIDs, and potassium sparing diuretics. As far as antacids are concerned, they may reduce the bioavailability of the angiotensin converting enzyme inhibitors. Capsaicin is concerned may worsen the ACE inhibitors induced cough. So, capsaicin must not be given in the patient who are taking the ACE inhibitors. NSAIDs, non-steroidal anti-inflammatory drugs, may reduce the antihypertensive response to the ACE inhibitors. Potassium sparing diuretics or the potassium supplements may exacerbate the ACE inhibitors induced hyperkalemia. hyperkalemia. They may induce the hyperkalemia. Additional benefits of the ACE inhibitors are these are the cardioprotective, reduced incidence of the second heart attack, reduced cardiovascular complications in the patients with the risk factors, reduce incidence of the diabetes in the high risk patients, reduce complications in the diabetic patients. These are the very safe in the diabetic patients also. Moreover, thank you so much for watching.